Guys, is go over clinical cases, I brought some clinical cases that we can do at the end, but I want to give you like the first thing I want to talk to you guys about is the bread and butter from nephrology and internal medicine, which is management of hypertension. I'm pretty sure you're going to encounter these in your career. Even if you're going to surgery, you need to understand the physiopath and the basics of managing patients with hypertension. Do you guys remember what the definition of resistant hypertension by the American Society of Cardiology, like American Heart Association? What is the definition of resistant hypertension? You guys remember, or have you reviewed that concept?
I don't have the definition, but we were reviewing before you came. We were just kind of reviewing hypertension, urgent hypertension, and emergency hypertension. Emergency, right? And then there is probably a more common kind of pathology, which is called resistant hypertension, and we see it all the time. And up to 27% of the hypertensive patients, they fulfill the criteria, which is essentially being on at least 3 agents, and one of them being a diuretic, maximum doses, and blood pressure still remaining like greater than 140/90. So, and I'm bringing it up because that concept of resistant, it comes down to not necessarily resistance, but pseudo resistance, because a lot of the times your job as an intern, when you're surviving your first year as an intern, your job is to get a good history and to be able to discuss. You spend the time with the patient. Your resident is more going to be like the leader of the team. It's going to be overseeing. The resident is not going to have the time to be like so specific about review of system or lifestyles and medication compliance and things like that. So I want you guys to get into the habit of being very thorough when you're interviewing patients and we're asking them, like the basics. And that's the teaching home from this talk. I want you guys to go home thinking about like the ABCs in hypertension. So the ABCs, whenever you're confronted with somebody with hypertension, you want to know things like compliance with medications, which is something that we think you're assuming that everybody's taking the medications, but before you jump and you start making a lot of changes, just assess compliance. How do you assess for compliance with a patient? How do you ask the question, or is there any other objective ways of knowing if the patient is taking the medications? Or yes, initially, kind of like we do here, we would just go through each medication, the dose, see how often they take it, and kind of listen to them, and if they have sort of more response, oh yeah, 25, sure.
Right.
Maybe kind of see how they respond to the medication, or if they say, yeah, 25 once a day, now I'm taking this. So if they seem to be more aware of their list of medications.
You think the patients are all truthful, are telling you the truth 100% of the times?
Nope.
You can look at their lab values or how they're presenting, like their blood pressure or if they have swelling.
True. You can assess like if they're whether or not they have some side effects from the medications.
I used to of like not taking anything.
Right. I used to have an attending that if someone is taking minoxidil, if you don't have facial hair, you're not taking it. It's funny, but anyway. So, yeah, that's another thing. What I want you guys to spend some time is looking at the bottle. Like sometimes we adjust medications and that information may not be accurate. But the other day I had a patient showing up with a prescription from last year, and I knew she wasn't taking it, although she was telling me that she was taking it. So just look at it like in some like settings like Dr. Ben-Zur, you already, when the patients are getting it, you can look in the electronic health record, when was the last time you guys prescribed it. But like if you really want to do the legwork, you can always call the local pharmacy and find out whether or not the patient is getting enough. Or you can do a pill count. Those are little strategies when you're confronted with like, really, is this patient compliant with his medications? But we hope. So where do you guys think most of the sodium is coming from in our society?
Canned food, canned boxes, the middle of the grocery store.
Exactly. Yeah. So processed foods. Processed foods, studies have shown that you tell the patient, oh, don't add extra salt. Oh, I don't add extra salt. So you think you're doing a good job. You're not. You actually have to go in detail, asking your patient, like, just tell me what you had for breakfast. Tell me what you had for dinner. TV dinners, frozen foods, canned, foods, in addition to other things that are obviously very salty, capers, olives, and all that stuff. But the bottom line is that you need to assess for processed foods, and that's where most of the sodium comes from. I'm going to share this is a clinical case that I have, a patient with recurrent kidney stones, and one of the fundamentals of managing somebody with recurrent kidney stones is to recommend a sodium restricted diet, because sodium increases, high sodium increases reabsorption of calcium and further stone formation. So I had a lady, recurrent stone former, and I decided to go ahead and assess her 24-hour urine sodium. That's one of the ways you can assess for compliance with a sodium restricted diet. You can order a 24-hour urine sodium, and you order a 24-hour urine creatinine. The reason why we always order a urine creatinine every time you do a 24-hour urine study is because you wanna make sure that the collection was adequate. And roughly for a female is about 15 milligrams per kilogram production of creatinine. For a male, we have more muscle mass. It's about 20 milligrams per kilogram in a 24-hour period. So when I have a number that's off, I know that the patient either under-collected or they over-collected. So that's if you want to be very academic, very strict, you always order a 24-hour urine creatinine along with the whatever study you're ordering. So to my surprise, because the lady was telling me I'm eating a sodium-restricted diet, blah, 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 blah. So when you get that result, you need to multiply that result by 23, which is the molecular weight of the sodium. And that gives you the amount of milligrams that somebody's having in a 24-hour period. So to my surprise and to her surprise, the lady was ingesting over 7,000 milligrams. And then obviously that was a big thing that the lady, and she didn't know, like she thought she was doing a good job, and it's not because she wasn't non-compliant, it's just the way we eat in America. It's just, it is what it is. There's a lot of sodium in the food, especially if you eat out. For your heart patients, when you deal with Dr. Ben-Zur's heart patients, if they eat out, there's no way you're eating a low sodium diet. There's no way. You can't control your sodium intake if you eat in a restaurant. It's just that simple. So when you have your patients with recurrent heart failure or patients with severe hypertension, the best advice you can give them is you need to cook your own meals. You need to cook your own meal. You need to be in charge of your own meals preparation. Anyway, so that's one of the things that you were mentioning. Sodium is huge in terms of hypertension management. So what other things? You mentioned lifestyle modification. You cover the sodium. What else in terms of like the basic stuff? What I call the ABCs.
So going back one step to lifestyle modifications with exercise.
Excellent. Exercise. So advice for every patient in this clinic, you're gonna hear over and over from Dr. Ben-Zur. Exercise is fundamental. Exercise is one of the few things that have really shown that improve your survival in every cardiology studies, like patients that are active, patients that they're able to push themselves to beyond their limits. Those are the patients that do better. And in hypertension medicine, we deal with we know for a fact that patients that exercise, that has a positive effect in reduction in systolic blood pressure readings. All right, what else? What other lifestyle modification? Smoking, yeah, we always advise patients to smoke, but probably the numbers are not, the impact is not that big in hypertension, but it doesn't mean that we shouldn't advise everybody to stop smoking.
Stress modification?
Stress modification for sure. There is an entity called Pseudo Pheochromocytoma. Have you guys heard about that? I'm sure you heard about pheochromocytoma, but Pseudo Pheochromocytoma. So patients with Pseudo Pheochromocytoma, they have a syndrome when they resemble the biochemical excess, like they actually have the same syndrome, the flushing, the palpitations, the paroxysmal hypertension, without the biochemical evidence of pheochromocytoma. And it's actually interesting because a lot of these patients are females, and a lot of these patients, they have underlying anxiety mechanism driving the blood pressure with this paroxysmal hypertension crisis. So yeah, stress modification, we all know that definitely that's a negative impact in your health. Stress is a killer. We all know that. All right, what else? Sleep. They've done studies. I actually recently did an interview about sleep, and then yes, there is a increased risk of cardiovascular disease for patients that don't have enough hours of sleep. But what else? What is this huge? What else is Dr. Ben-Zur advising to all of his patients?
Meat, red meat.
Yeah. Diet. Well, now that you cover that, like plant-based diets are actually a lot more effective for both hypertension and diabetes control. After many years of listening to Dr. Ben-Zur, I finally, and you're gonna like this, Dr. Ben-Zur, I finally became a plant-based eater exclusively. I'm exclusively eating plants for the last 8 months of my life, and I feel like I've never felt before. So,
I can't believe it.
Yeah,
I still walk into the kitchen 5 minutes after plant-based.
Yeah.
I have to have my chicken.
Seriously, and part of it is that, it's really funny because I did it because I wanted to inspire my patients to help them, because I felt a lot of the time my patients are hopeless. They have the whole metabolic syndrome package, and there's nothing I can do for them, and they don't realize, like, after you hear this concept over and over, food is medicine. Food is medicine, and it's so important that we teach our patients that, because a lot of these chronic diseases, a lot of the, like, when you guys are here, try to learn more about this, because this is a great opportunity. There is a documentary. Dr. Ben-Zur even gave an interview. I don't know if you guys have seen it, the Forks Over Knives. There's so many Food Inc. There's so many different things that you guys can learn about it. But now that we're specifically talking about hypertension medicine, yes, we have evidence-based research showing that plant-based diets are efficacious, improving metabolic control, reducing your heart risk, and improving hypertension and diabetes control. So that's something that I advise to all of my patients. And like I said, if I don't do it myself, how am I going to be advising my patients to do such a thing? So you guys need to inspire your patients, because when you're doing this for some time, you realize, like, a lot of the, like, medication is not the answer. Medication is just not the answer. These patients, they go on a spiral, more and more medications, more disease, less activity, less, like, worse lifestyles, and they end up on dialysis or having MIs or congestive heart failure. And you can really make a huge difference if you're able to inspire your patients to change their behaviors, which is the hardest part to do in life, changing behaviors. Okay, so very good. So and weight reduction. That's basically the other thing that we do, that we advise our patients. Weight has an impact in reducing your risk of sleep apnea, and you probably heard about secondary hypertension and sleep apnea. Like, if you were to look into obese patients, most of them will have, I would say probably 80% of them will have some degree of sleep apnea. Whether or not that makes a huge difference, actually they've looked into it, and when they successfully treated patients with the sleep apnea, the impact on systolic blood pressure control is pretty negligible. It's only like 3 to 5 points at the most. But it doesn't mean that we shouldn't advise our patients to treat their sleep apneas, because we all know that sleep apnea is associated with reduced quality of life, increased risk of motor vehicle accidents, increased risk for right ventricular heart failure, like cor pulmonale, strokes, and all sorts of like atrial arrhythmias. So patients with severe sleep apnea, that's something that we shouldn't ignore. But when it comes down to hypertension, secondary hypertension, yes, it is strongly associated, but that's not where the money is. The money is in the sodium, the physical activity, the weight reduction. That's where the money is, and medication compliance for those patients that are really having like resistant hypertension. So, having said that, if you realize, like, all the things that I just said, we have a lot of pseudo resistance. So from those epidemiologic data that I show you, that about 27% of the patients have resistant hypertension, we can probably cut that by 50%, because it's not really resistant hypertension, it's pseudo resistance. So you guys know that when you're confronted with a hypertension patient, you need to cover your basics, the ABCs, the things that I just mentioned, and then you move on. And then I'll tell you, like, I talk a lot with the primary doctors about hypertension, because I'm the hypertension champion for my medical center. So I do a lot of, like, education and outreach and strategies to be able to improve our hypertension control rates. So for our patients, the key is in the effort that you as a provider put on your patients, educating them, telling them hypertension is bad, it's a killer. And when I let go, when I discharge a patient, I tell that patient come back in 1 year, and I know that this person's blood pressure is 145. A lot of things can happen in 1 year. A lot of things, including a stroke. So your job as a provider is to educate your patients and tell them, you know, we need to be able to bring these numbers down. And I keep bringing them every 2 weeks until the numbers are actually fine, and I let them go. If I feel that the patient needs to be followed once a year or whatever the case is, I just make sure that I get this number under control before I let them go. So that takes me to the next topic, which is educating your patients about side effects. And educating the patient about first line, second line, third line agents for blood pressure control. And this is a very important topic, because when you're ready to give up on a medication, make sure that you think about it twice before you give up on a medication, because the next thing you know, you're dealing with like third line agents instead of like the first line agents. So you guys are probably very savvy about side effects of antihypertensive medications. I'm just gonna be brief and shallow on this part, but let me know if you have any questions. So you guys know from JNC 8, which are the medications that are first lines? You guys remember from JNC 8? You guys remember which medications we use? Diuretics. Which diuretics? Thiazide diuretics. Okay, so thiazide diuretics, they're very effective. There are a few things that you need to do before you prescribe, especially if you're working in an urgent care setting. You're going to want to know that you're kind of required to have labs before and after, before you prescribe a thiazide. Why? Because a small percentage of patients can have like electrolyte abnormalities, including severe hyponatremia, which can be serious. So if your patient has had a history of hyponatremia, you probably want to stay away from the thiazide. The thiazide-induced hyponatremia, we know that mostly elderly females that are not eating 3 meals a day, those patients are particularly at higher risk. It doesn't mean you shouldn't prescribe a thiazide in an elderly female, but at least make sure that you take a look at the previous sodiums and make sure that they're all being normal, and that you advise the patient like you're not going to tell me go eat sodium, because that defeats the purpose of prescribing an antihypertensive medicine, but you may want to make sure that they're eating 3 meals a day. You know, like the typical medicine textbook, like the tea and toast, like the frail old lady that she doesn't cook anymore because she's on a limited budget, or she doesn't really have anybody to cook, and they just learn how to live on tea and toast. So that's actually pretty common in clinical practice. You're going to see like these frail ladies that are very thin. So those patients, you got to be cautious. You know, it's not a contraindication, but you got to be cautious and make sure that you recheck labs in about a week. So, and what's novel about these new recommendations on JNC 8 is that they elevated the amlodipine to the same level as the thiazide, as the first line agent. So when I tell students is that amlodipine is a great medication, because if you're working in the urgent care setting, you need to look at labs. You need to look at labs before and after. So that's why the utility of amlodipine is a very good medication, because you can start them and you know that they don't have any significant metabolic effects. What are the most common side effects from amlodipine? You guys remember?
Systemic hypertension.
No, calcium channel blockers not so much, but yes, but that's more for the nifedipine and like the non-dihydropyramide calcium channel blockers.
Peripheral edema.
Peripheral edema is quite common. It's actually in this again. It comes down to you be able to educate your patients about the peripheral edema. It happens in about 5, in some series up to 20% of the patients can develop peripheral edema. If it doesn't bother them, it shouldn't bother you, because it's almost so common that you need to teach the patients. And what are the strategies to minimize the risk for the peripheral edema? Compression stockings, elevating legs, eating low sodium, which you should have advised your patient to begin with from the beginning, and also just to cut down a little bit of fluid. So there is this conception in the community, in the general population, that drinking a lot of water helps. And I see that all the time, like patients like in kidney, particularly in my field, patients that come in like, oh, I'm drinking 150 ounces a day because I want to flush my kidneys and I want to be able to bring down my numbers. And you need to teach your patients, when you have kidney disease, the more severe the kidney disease, the more restricted you need to be with your fluid consumption. And just think about, like, if you have a reduced GFR, like the example that I use for my patients is, just think about, like, if you have a clogged sink. If you start putting a lot of water, you're going to overflow. The same thing happens in kidney disease. If your GFR is 30, 31, and you don't pay attention to the salt intake and you drink a ton of fluid, for sure you're going to come with severe edema, for sure, guaranteed. Because that kidney doesn't have the ability to dilute or to concentrate like a healthy kidney. So same thing with Dr. Ben-Zur's patients. He has a lot of patients with severe heart failure. They come in, and the general recommendation is that these patients shouldn't be on more than 32 ounces. And do you guys know what 32 ounces, how much is that bottle? It's probably a liter, right? That's what a advanced kidney disease patient and advanced heart failure patient should have in a 24-hour period. Only that, accounting for everything, accounting for juice, coffee, tea, whatever you drink. That's not a lot. And then patients think like, oh, I'm gonna be healthy, I'm gonna start drinking. So when you're confronted with this edema, like calcium channel induced lower extremity edema, it's very easy to fix if you educate your patient from the beginning. So especially for those suffering from severe heart failure and severe kidney disease. Okay? So basically, by going back to the thiazides, what other metabolic side effects do you guys remember from the thiazides? You guys? Gout, definitely, yeah. Gout is a big thing, and sometimes it becomes so annoying that it's limiting the use of these medications. Yeah, gout is definitely, especially in kidney disease, the more advanced the kidney disease, the higher the risk of developing gout and a thiazide. I usually, when the GFR drops below 30, I usually get rid of the thiazide because it's ineffective, and the side effect profile risk outweighs the benefit. At that point, I think about like switching the patients to a different alternative agent. In advanced kidney disease, like nifedipine is actually the agent of choice. I don't know what would I do without nifedipine in my practice, and that's why I'm so keen about like educating my patients about side effects on the calcium channel blockers, because you really need them. And if you write them off, then you're moving to a less desirable choice. Okay, so what else do you guys remember from calcium channel blockers? Side effects from amlodipine in particular. That's in your boards. You're gonna get that question. They're gonna show you a picture of the side effect, and they're gonna tell you which medication is causing this.
Is that the calcium channel blocker that has severe constipation or severe constipation?
Constipation is the side effect from calcium channel blockers. It can be severe, especially for verapamil and diltiazem. But there is a side effect that's common, and it's tested on the boards. I got in my nephrology boards. I even got it.
Does it deal with sugar imbalances?
No, it actually do with gingival hyperplasia. So they're gonna show you a picture of a person with like big gums. So just make sure that you don't forget that one. And is it a serious side effect? No, but do you want to have gingival hyperplasia? So it can be annoying to patients, and you have to dose reduce. Is dose dependent, the same thing as edema. But ultimately, when the patients end up developing this, in my experience, I generally have to switch them to an alternative agent, because it's the patient are going to be on you. And the bad news is that even if you switch the patient, the gingival hyperplasia may stay. So yeah, so that's one thing to remember for your boards here, because you may get tested on that. But in general, again, calcium channel blockers, especially amlodipine, is a great starting medication because it's not very strong. You can start titrating 2.5, 5, maximum 10 milligrams. Sometimes we see doctors going up to 20 milligrams. The reality is, like, if you look at the box insert, the recommendation, the FDA recommendation, the maximum dose should be 10 milligrams. You don't have to combine it with any other. You can do it as a solo therapy. Another thing that's novel from the JNC8, these are like important concepts, like bullets, points that I'm giving you guys, is that before we used to treat patients with hypertension with beta blockers as a solo therapy. We no longer recommend that. It's been discouraged with evidence-based research because beta blockers are weak blood pressure agents, and it should never be first line compared to a thiazide diuretic and compared to a calcium channel blocker, amlodipine type. Another thing that it's important to know in terms of the thiazide diuretics is that chlorthalidone, it's longer life compared to hydrochlorothiazide. In my practice, I prefer to prescribe chlorthalidone because it's stronger and it's a longer lasting. Like the half-life is 24 hours versus 18 hours on hydrochlorothiazide. But with stronger treatment response, it also the incidence of the metabolic side effects is also a little bit stronger on the chlorthalidone. But the incidence of electrolyte disturbances and the incidence of hyperuricemia and gout is a little bit slightly elevated on chlorthalidone. But in my practice, I usually use chlorthalidone over hydrochlorothiazide. One thing that very commonly happens when you're working is that there is a lot of combination drugs. I usually stay away from them because if the patients have a side effect, like the patients are gonna say, oh, these two medications, these two ingredients are giving me an allergy or giving me an intolerance. So it's difficult to convince people when you're taking them off a combination pill and just re-exposing them to one of the ingredients. And also the reason why I stay away from them, it's because when you start a medication, that's one of the principles in hypertension medicine. To be able to call it resistant hypertension, remember I told you, it's 3 medications on maximum doses. So a lot of times you start one and then you add another one and then you add another one, and to me that's not good practice because you want to maximize the agents before you move to another one. So that's another reason why I try to stay away at the beginning with combination, and I may switch patients with combination medications at one point, but when I'm confronted with a new patient, I usually start them with one medicine at a time. Do you guys remember which medicines they come in combinations? You guys remember?
TMPS and Max.
Triamterene, the Maxide, is that what you're saying?
Yeah. I'm sure.
Triamterene and hydrochlorothiazide, Maxide. Which other medications you guys remember? So like A's and thiazides are very common. ARB and thiazides is also another very common combination. There are some combinations of calcium channel blockers and thiazides, but they're usually they're not generic, they're prescription medications. But the ones that are generic are primarily thiazides and ACE inhibitors, thiazides and ARBs, and diuretics. They come in combination, and the Maxide usually. Okay, so those are the two medicines. And I didn't mention about nifedipine as a first-line agent because nifedipine is powerful. Nifedipine, one of the side effects is the reflex tachycardia. So, like in my practice, I usually prescribe a beta blocker before I jump into nifedipine. And the reason being is that if you don't beta block these patients, they will come to you after 1 or 2 weeks saying, like, I don't want to try this medication, it made me feel terrible because they may have these palpitations. So in general, I usually beta block my patients when I'm ready to give them a calcium channel blocker. But the first calcium channel blocker I use is usually amlodipine. Okay, so which other medications you guys remember? Blood pressure medicines. ACE inhibitors, great. So that's what I do for a living, right? I believe in the power of ACE inhibitors, and you better believe in the power of ACE inhibitors. So the teaching point for students is that we have compelling evidence that ACE inhibitors are very effective in slowing down progression of kidney disease, and they're also very effective in patients with heart failure and remodeling the myocardium, and they do have like a mortality benefit. So you have to have a very strong reason not to use them, and this is a take-home message from this talk, is that you need to educate your patients that they should be on either an ACE or an ARB. And the other teaching point is that they're equivalent. In every study, when they've done head-to-head and non-inferiority trials, they're as effective, ACE and ARBs. Whether you use an ACE or an ARB, that's your problem. I usually start with an ACE. It doesn't really matter if they develop. The most common side effect of an ACE inhibitor is a cough, like this dry throat, the scratchy throat, the non-productive cough. You can see it up to 15-20%. If your patient develops it, you can always switch them to an ARB. And you need to tell them that the cough is going to be there for a while, for about 4 weeks, otherwise they get frustrated, and after 1 week they want to give it all up, and you don't want that. You want to educate your patients that these medicines are very powerful and they're very good agents. And do you need to have labs before and after you prescribe these medicines?
Yeah.
For sure, you have to. And what are the metabolic side effects from ACE inhibitors you guys need to be aware of?
We were talking about it, yeah.
I'm sorry? Hyperkalemia. So every time I prescribe a ACE inhibitor in my practice, because I deal with kidney disease, I have to educate my patients about potassium. Otherwise, I'm not doing a good job, because I'm going to send the patients out, they're going to keep eating whatever they're eating, and they're going to come back with hyperkalemia. So which are the foods that are rich in potassium? Which are the foods? Kale and spinach, they have a lot of potassium. Bananas, yeah, you said it. Yeah, absolutely. Bananas, what else? I want you to mention at least 10. I'm not going to be happy if you don't mention 10. You already mentioned 3. Banana, kales.
Kale used to be a condiment in America at Denny's, and now it's become a salad. Very green and very dry.
Yeah, it's pretty common here. A lot of people, they do like shakes. They put it like in like green drinks. And then that's another problem that I have with my kidney disease, especially when you tell them you're in trouble, they go and they all start eating like shakes and greens, and they all become hyperkalemic. So I have to really spend a lot of time in educating my patients about potassium. But I want you guys to memorize these things, because you need to know this. You're going to be prescribing ACE and ARBs. And so what else? Well, other foods. What do we love here in California is everywhere.
Avocado?
There you go. Avocados is everywhere. It's delicious, and we all love them, but unfortunately it's one of the highest potassium foods. Another thing that's quite popular in this healthy living, these new trends, patients, they drink a lot of coconut water. Coconut has a lot of potassium, so it's dangerous. Actually, if you have a patient with advanced kidney disease taking an ACE or perhaps a spironolactone, and they start drinking a lot of coconut water, they'll be in trouble. So make sure you tell them those things. So potatoes have a lot of potassium, unfortunately. Beans have a lot of potassium, unfortunately. A lot of the fruits like tomatoes, they have a lot of potassium. A lot of the fruits like strawberries, melon, persimmons, like fruits that are cool or that are kosher for kidney disease patients. We have grapes, small quantities, because it's not only the food choice but the quantity. I have a patient who's funny. I told him you can eat grapes, and the guy's potassium was super high. Are you eating grapes? That's all I eat. Wait a minute, how many grapes? The whole thing. Well, it's not just the food choice but the quantity. So if you're eating a lot of grapes, for sure you're gonna have hyperkalemia. So just make sure you explain that concept to the patients. Yeah.
How do you deal with a patient, because we've had a few here, that they really just, when you talk to them about diet, their main thing is, so what can I eat? I can eat nothing. Kind of like they just get very dramatic about how
right.
what they're used to eating and the taste, now they're just going to eat things that don't taste good anymore.
Well, I'm going to tell you what I tell them.
Their health is more important than what they're eating.
I'm going to tell you what Dr. Ben-Zur just said. I was born and raised eating meat for breakfast, lunch, and dinner. Now I have no meat. So they have to, they have to really believe in it. They have to believe in what the doctor says, and that's why it comes down in having a good patient-physician relationship, and we're teaching them tips to be healthy. You do a non-confrontational approach. You do a bi-directional feedback. You wanna sit down and spend a few minutes with them. So what do you eat? So have you thought about replacing perhaps that for a plant-based option? You can teach the patient using examples. The problem is that it's very difficult to change behaviors, because a lot of the times people they really think there's no other way of eating, and I include myself into that category, and I'm an educated person. So you can imagine trying to educate somebody with a very low educational level. Remember, in America, we're talking about people to be an effective communicator, you need to be talking to your patient at a 3rd grade level. And we always forget about that. We always become technical. We use these $5 words to talk to our patients. To be an effective communicator, you need to be able to sit down, let them talk, and you do the talking and then let them talk back. But it's this concept of educating patients in one direction, the way we were taught in medical school, or at least the way I was taught in medical school, is part of history. You need to be able to sit down with them and let them express, understand their background and their needs, and so they can get back to you. And we have enough resources to educate the patients, but you need to. The only way you can actually build trust is if when you let them talk and you're able to listen to them. So that's the strategy that I use. They tell me, so what I'm gonna eat. Like for instance, my Latino patients, I tell them like, you can't eat beans, and I tell them like, wait, I'm not telling you cannot eat beans, but what you need to do is you need to double soak those beans. You need to put them in water, get rid of that water, and then cook them again. And that concept like resonates, and that stays with them. And say like, oh, the doctor said I can eat my beans, but I need to do this exercise every time. Like for instance, canned pineapple has a lot less potassium than fresh pineapple, believe it or not. So there's a lot of little things that when it comes down to nutrition, and that's why I think like we all as physicians, we need to learn more about nutrition. I think the medical education in the United States is insufficient about teaching us about nutrition, and they're missing the big point. The mother of all medical problems in the US is the way we eat. There's no question about that. And do you guys feel, I'm going to ask you this question, I want an answer from you guys. Do you feel that you guys have spent enough time in nutrition in your medical education? Hell no. And even medical educators, even deans, even like professors and everybody, they're missing the big point. The big point is teaching us to be able, so we can teach our patients to eat. And that's a huge concept. That's why, you know, I'm very thankful that Dr. Ben-Zur made me understand this concept. And it was a decade process for me to understand, believe it or not. And why was I able to understand this concept? Is because I got fed up with chronic disease. And you're gonna see that after you do this for some time, you're gonna be fed up. You're gonna be like, boy, how can I help this poor guy? This guy is heading for dialysis. That's all I do. Like I meet a guy, and the minute that I meet that person, I already know that I have a dialysis patient in front of me. There's nothing I can do. And some of them listen, and I'm saying some of them, I'm talking about like very few, like probably like less than 10%. And a lot of them won't listen. They still will have the same lifestyle, they still will eat the same crap. I'm sorry for my vocabulary, but I just want to make sure that you guys spend some time to inspire your patients and to understand that this is the big picture. The big picture, the patients talk about the small picture. The patients, they come in like, oh, so my number is 35 and last month was 32, so I'm getting better. Like, that's not the big picture. The big picture is like, you have a progressive type of disease and you're going to end up on dialysis. And there's very few things that you can do. And the very few things you can do is, number one, ACE inhibitors and ARBs. Number two, the way you eat. Food is medicine. I want you guys to learn that. Food is medicine. When you go home and you're ready to educate your patients, this is something that needs to stick with you, guys, from now on for the rest of your practices. Okay, so ACE inhibitors. So I mentioned some of the foods: potassium, bananas, potatoes, tomatoes, avocados, pretty much the whole Mexican diet. So it's very sad, but and then that's why I have a lot of problems with my patients to be able to start eating in a different way. But fruits that are okay: pears, apples, and grapes in small quantities. And believe it or not, processed foods, they have a lot of potassium. And then that's one of the things you can teach your patients. So what am I going to eat? So I'm telling you, you can eat the salad if you give up these processed foods. So you can negotiate with them. You can just tell them, you can do this if you do this. And one of the things that you can tell the patient, you don't have to panic about this, because we're actually measuring your potassium. That's one thing that you need to teach your patient. We're measuring, we're not ignoring you, we're measuring your numbers. So you reassure them, and that way you build confidence that this medication is going to help them, and they're not going to be left alone. Okay, so basically, if you have a patient with kidney disease, make sure you spend some time and you educate them about potassium, and you document that in your note. If you give, let's say you have a patient with a GFR of 20 something, and you don't educate them, and the patient goes and do whatever, and then they die. People die from hyperkalemia. You guys know that, right? Hyperkalemia is a fast killer. Like I tell my patients, my kidney disease, my dialysis patients, you have two enemies. One guy can kill you overnight. The other guy can kill you in months or years. You guys know the one that can kill you overnight is potassium. You know, it's very irritating for the heart tissue. It actually caused a lot of conduction abnormalities, and you probably know the EKG abnormalities. We can review them, like the EKG associated abnormalities with hyperkalemia, and you can actually go to radi and like a very wide tachycardia, and people can die from this. And the second enemy is phosphorus. We can actually spend some time some other day about phosphorus, but phosphorus is actually an independent risk factor for coronary disease and cerebrovascular disease, and that's actually probably one of the most important predictors of outcomes when you're a dialysis patient. If you're unable to get your phosphorus under control, you're not going to do well. In other words, the example that I use to patients is like you're aging twice as much when your phosphorus is greater than 5. And you know, I see this all the time. Like my dialysis patient, they eat, and guess what? Which one is the food that has the highest phosphorus, by the way? Which one?
I don't know.
I want you guys to learn these things because you're going to be teaching your patients good stuff. So milk, and milk is actually a terrible food for all of you guys. So I want you guys to learn more about how bad milk is for all of us. So milk actually has a lot of phosphorus and is a terrible choice for a dialysis patient. No dialysis patient should be drinking any milk or any dairy or any milk derivatives. But phosphorus is also in a lot of the processed foods, and a lot of like dark sodas, processed food, nuts. Unfortunately, nuts. Nuts are very healthy, but nuts have a lot of phosphorus. And cheese and milk and yogurt and all that stuff. So a lot of the phosphorus comes from that. But anyway, phosphorus is unrelated to this topic for hypertension. We just got detoured a little bit because I wanted to teach you something else. Okay, so going back to the ACE inhibitors. So you want to be able to have baseline labs before you prescribe an ACE inhibitor, and by the same token, you want to be able to recheck renal function in about a week after you prescribe an ACE inhibitor. So what am I looking when I recheck the labs? I'm looking at the potassium level, and what else am I looking? Creatinine level. So this is the example that I want you to use from now on for the rest of your careers when you're explaining your patients about ACE inhibitors, because these days patients are very well informed. Patients have access to their information. A lot of the healthcare organizations are providing the patients with passwords so they can go and they can look at their trends. A lot of the labs are actually moving in that direction so the patients can actually go and look at their numbers. So when you prescribe an ACE inhibitor, it is expected that the GFR is going to drop. It is expected. And sometimes the drop is a lot, sometimes the drop is a little bit, sometimes there's no drop. But you tell the patients that the GFR is going to drop. And the way I explain to my patients is like, that engine, you have an engine that is actually running at 5,000 revolutions per minute. I'm trying to, by prescribing this medicine, I'm trying to bring down that engine to 2,000 RPMs. Because I know if I bring down to 2,000 RPMs, that engine is going to last longer, which is your kidneys or your heart, whatever example you want to use. But when you explain that to them, they understand, oh, okay, so the doctor told me GFR is going to drop, but this is going to be beneficial for me. And I'm not lying to them. I'm just basically telling them, just using a simple example, and that stays with them. So that's why if you see a drop, let's say that it's 20%, don't stop it. Just check it next time. Check it like probably in a week. And if it's dropping more, like, yeah, you better stop it, right? But be confident about your knowledge and be confident about like the tools that you're doing. Like if the drop is dramatic, like 25-30%, yeah, stop it. But textbook definition, up to 25% drop in the GFR, you're good. If you drop 20%, just tell the patient, you know, why don't you come next week and let's do another GFR assessment. Simple test, just a blood draw, and you can reassure the patient. So to me and to my students, I always tell them, you have to have a very powerful reason not to prescribe an ACE inhibitor. Which one is that reason?
Hyperkalemia?
No, hyperkalemia is manageable. You can prescribe medications. Now we have agents for chronic management of hyperkalemia. But I'll tell you, you don't need any of those agents if you teach your patients the basics of a good diet. Or you can even refer to a clinical nutritionist. So there is one absolute contraindication to re-challenge an ACE inhibitor, which is? History of kidney dysfunction? No. Actually, that kidney disease, they need an ACE. If you're not giving a kidney disease patient an ACE inhibitor, you're actually doing a disservice to that patient. Angioedema. So angioedema, you can kill someone. So make sure that if the patient did develop a true angioedema, you can still, if you're brave enough, and there's no wrongdoing with this, you can still challenge them with an ARB. And you can prescribe an EpiPen. You can tell them, like, you know, if you want to just do it when we're here in the office. The cross reactivity is about like 10%. I had a patient with a real angioedema, and I was brave enough to give him an EpiPen, and I re-challenged him with an ARB, and he did fine. He didn't have that problem with losartan. So just make sure that, like, that's the teaching point home is, like, you have to have a very good reason not to give these medications to your patients. And it's not first line for hypertension, but it is first line across the board for patients with kidney disease and for patients with heart disease. So that's the bottom. That's a very strong indication. And then they reduce proteinuria. You know, they have all sorts of beneficial, like the blockade of the renal aldosterone system. It has all sorts of beneficial effects in the body. Okay. So moving on to other alternative agents, we already talked about one diuretic, so we're going to talk about a very powerful diuretic that is going to be your next step every time you have a patient with resistant hypertension and you're thinking about adding a fourth agent. The name of this medication is? Thank you, spironolactone. So spironolactone is a very powerful antihypertensive medicine. There are many uses in medicine for this medication.